Before we begin, if you struggle to remember high-yield medical concepts, I've created a clean medicine mnemonic pack that turns topics like this into fast, exam-ready memory tools. Link is in the description below. Acute pancreatitis is an acute inflammatory disorder of the pancreas and surrounding tissues, caused by autodigestion from leaked pancreatic enzymes. Under normal physiology, pancreatic enzymes are synthesized as inactive zymogens and activated only in the duodenum. In acute pancreatitis, this protective mechanism fails, leading to premature enzyme activation within the pancreas itself. The central pathological event is leakage of pancreatic enzymes into pancreatic tissue. Activated trypsin triggers a cascade that activates other enzymes such as lipase and elastase, resulting in autodigestion of the pancreas, surrounding fat necrosis, vascular injury, and an intense inflammatory response that can rapidly become systemic. The most common risk factors are gallstones and heavy alcohol use. Gallstones cause transient obstruction of the pancreatic duct, increasing intraductal pressure and promoting enzyme activation. Alcohol directly injures acinar cells, increases enzyme secretion, and thickens pancreatic secretions. Other causes include hypercalcemia, hypertriglyceridemia, abdominal trauma, drugs such as thiazides, sulfa drugs, statins, valproic acid and protease inhibitors, viral infections like mumps, autoimmune disease, ERCP, and rare causes such as scorpion sting. Patients typically present with sudden onset severe epigastric pain radiating to the back, often accompanied by nausea and vomiting. Systemic inflammation may cause fever and chills. On physical examination, epigastric tenderness is common. Flank ecchymosis, known as Gray-Turner sign, or periumbilical ecchymosis, known as Cullen sign, suggests hemorrhagic pancreatitis and indicates severe disease. Initial imaging includes abdominal ultrasound in all patients to evaluate for gallstones and biliary obstruction. An abdominal radiograph may show a sentinel loop, representing a localized ileus near the inflamed pancreas. Contrast-enhanced CT of the abdomen and pelvis for patients with signs suggesting necrotizing or hemorrhagic pancreatitis. CT findings include pancreatic enlargement, necrosis, peripancreatic fluid collections, pseudocysts, or abscesses. Laboratory studies typically show elevated serum amylase and lipase, with lipase being more specific. Hypocalcemia may be seen due to fat saponification. The diagnosis of acute pancreatitis requires 2 of 3 criteria: characteristic epigastric pain, serum amylase or lipase, elevated to at least 3 times the upper limit of normal, and imaging findings consistent with pancreatitis. Management is primarily supportive. First-line therapy includes aggressive intravenous fluid resuscitation, electrolyte correction, adequate analgesia, and early enteral feeding as soon as tolerated. Nasogastric decompression may be used if ileus or persistent vomiting is present. ERCP followed by cholecystectomy is indicated in gallstone pancreatitis with cholangitis or persistent common bile duct obstruction. Surgical debridement is reserved for symptomatic necrotizing pancreatitis. Complications include pancreatic pseudocyst formation, pancreatic abscess, hemorrhagic pancreatitis, pleural effusions, often left-sided, progression to chronic pancreatitis, and disseminated intravascular coagulation. The severity of acute pancreatitis depends not on enzyme levels, but on the magnitude of the systemic inflammatory response and early supportive care. This is the Why Medic. Subscribe for more high-yield topics.